This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. LaFredo, and this week I'm coming to you from KRMC Hospice. My guests are Candy Huerta, RN. She is the Director of Home Health and Hospice, and Susan Shaver, RN. She's the Clinical Manager of KRMC Hospice and the Joan and Diana Hospice Home. Ladies, welcome.
Thank you. Thanks for having us.
I am happy to be here. I'm happy to visit with you again. We try to get together from time to time, and I checked my records and found out that the last time we got together it was, I think, toward the end of 2020.
That sounds about right.
Yeah, and I'm sure those are some of your favorite moments of your career.
Always.
We were still very deep in the pandemic. And while you were lovely in having me in, I did sense a bit of COVID fatigue going on here.
Most definitely. That was a very challenging situation for everyone, not just healthcare. But at that time, it was a resounding yes to you were picking up on. Yes.
Do you want to tell me a little bit about, I don't want to dwell on it. Nobody wants to go back. But you are in the business of solving problems, and you had been doing that for a long time, and suddenly foisted upon you was a whole new set of problems.
Most definitely. So we had the opportunity to take care of everyone in the community as well as the hospice home during COVID, whether they had the virus or not. We went into their homes. We did not hesitate. Having been a nurse for 20 years, and I know Candy's been a nurse at least 10 years longer than me, when the pandemic came about, we were very confident in our skills and our abilities, as well as the skill and ability of our staff to provide care to patients that needed home health and hospice services. We had all of the PPE that we needed, thanks to being associated with KRMC. So there was no hesitation. Patients needed care, we provided it.
Yeah.
Yeah, absolutely. We had a team that absolutely did not hesitate to go into the homes and care for these patients one-on-one with or without the virus. So they did well.
Yeah. And as the pandemic eased, did you sort of do a collective postmortem on how it went and what you did? Or was it more like day to day, another day, we've got to show up, we've got to do the work?
We just carried on, but there was a sense of relief. We saw the end of it coming. Hospice is Medicare certified. We follow all of their regulations to a T++. So as we're watching how Medicare is evolving through this pandemic, it was easy for us to see when things were starting to wind down. As things started to wind down, we all collectively took a deep breath. We were thankful that we made it to the other side. We were curious about what healthcare would look like at the end of the pandemic and how we would be taking care of our patients based on what we learned. Yeah. So we did very much sigh in relief that it was all over.
Sure.
And we could sort of go back to business as usual. It just looks different now. Yeah. Healthcare looks a little bit different. And my personal opinion is we're still sort of reaping some of the challenges that we accumulated, which is, poor access to care. Patients weren't following up on their chronic disease management. People were being diagnosed late with different conditions that have a terminal code added to it, I guess. And that always complicates life when you are suddenly stuck with a disease process that has previously been managed well, and then we come out of the pandemic and it's not as well managed or has progressed to a point where treatment options are limited.
Yeah. I've been doing interviews for the hospital for 12 years, and I've always resisted politics in the conversations because while politics and policy can often be relevant to healthcare, there's no sense. What we're here to do is share useful information, not to alienate half the population.
Absolutely.
But it must also have been just heartbreaking for you to see your work become subject to a game of political football.
Oh, yeah.
Yeah, but I think, and as nurses, we just did our job. We continued on with the patients. The patients and their families were our focus. I don't think we really paid much attention to that. We have people in our organization that's their job, so they would just kind of direct, hey, this is what we need to do now, and this is what we're going to do, and this is what we did. And KRMC made sure we had everything that we needed to carry on. So that's what we did.
Keep on marching.
Yeah, we didn't really put the politics into it. We just took care of our patients and did the best we could. So
at the end of the day, we don't need a politician to take care of our patients. So we are able to differentiate, and that's what we're taught as nurses. We're taught to be non-judgmental, to be unbiased, to be very patient-centered in the care that we provide, and that's exactly what we did.
You two are good at this. Well, let me tell you, the night before an interview, I'm always sitting and thinking, okay, what do I need to know? What do I need to prepare for tomorrow? And as we mentioned, we've done a few hospice interviews over the years. And so I have this impulse of saying like, oh, well, tomorrow we're talking about the inevitability of human death. That sounds like a cheery conversation. And yet, all the conversations have been great, coming in and speaking with you and your colleagues in different capacities over the years. And I guess what I'm getting at is there's something, you hospice folks are wired a little bit differently.
I would agree. I mean, you have to be prepared to have some of the hardest conversations you're ever going to have with a patient and their family. You are the bringer of bad news, in essence. So being in hospice does require a certain heart. You have to have a straightforward demeanor. Patients and their families deserve that. You have to be very confident because you're delivering bad news most of the time. The rest of the time is actually quite fun. I mean, you'll hear me say every single opportunity that I have that I get to meet the neatest people at the worst time in their life. It doesn't change the tone of the meeting, though. It doesn't change the tone of the visits. You still go and you do life review with them. You listen to them recount all of the amazing things that they've done, all of the feelings that they have, the foods that are their favorite, activities. I mean, it's just neat. Mm-hmm. Going into their homes, being invited in. It's a very private space that they're inviting you into. So after you've had the hard conversations and helped them understand that this is what your care team of physicians think is best for you, then it's actually fun. You actually get to go and teach and sit and maybe have your patient teach you something. Mm-hmm. It's a different type of nursing care.
And at the end of that workday, when you take off your ID and you go home, having listened to these folks and their families reflect on what's important, that has to carry into your personal life. Is it okay? Can I ask you about that?
Oh, yeah, absolutely. I mean, it really does. You go home and, I mean, we're all human. So some days you go home and you think, man, this day couldn't be any worse. I just had 6 of the hardest conversations. The families were not, the patient was not, the doctors were not. There, barriers. Sometimes, some days you just have a barrier every step. Other days it's a breeze, and you go home and I play with my dogs and I'm in a good mood and I smile. It's a different way of unwinding, but your day decides how you're going to unwind. Mm-hmm. If I go home and I am carrying this burden with me, because it doesn't matter how many years I've been doing this, I leave the majority of those feelings in the home with the families and the patient, but some of them go home with you. There's just no avoiding it. Yeah. And you process. I've got all sorts of different ways to process. I know all of the nurses have different ways to process and unwind. That part of the hospice care we provide is very individual. But yeah, we most definitely carry this stuff with us.
When families need to seek end-of-life care for a loved one, what should they consider in terms of services and resources? There's so much to keep track of.
Oh, there is. Things that they should consider when they need to seek end-of-life hospice care are the patient's goals. What does the patient want? That is our responsibility as the hospice staff members to make sure that we are respecting the patient's wishes first and foremost, if they're able to verbalize that or write it down on a piece of paper for us. So considering what the patient actually wants, and then making sure that the patient's wants and wishes are in line with the hospice philosophy. If they're not prepared for hospice care, it's going to be a very rocky road trying to get them on board and prepared. Some people are never ready. That's just a reality. And we respect that. We respect the fact that these patients are not ever ready to die. They are not ever ready for the end of their life, and it does not matter how much support you provide, how much paperwork you give them, literature to read, how many doctors they've talked to, it doesn't matter. So we have to consider that first and foremost. And then services and resources. Once you're on hospice care, services and resources are aplenty. We have just about everything that you would need to prepare for end of life. If you need a notary, we have a notary. If you need paperwork to fill out for, say, a power of attorney, we have the paperwork. We can bring it to you and assist you with filling it out. FMLA paperwork for your loved one. If you're going to be the primary caregiver, go to your employer and get the FMLA paperwork now. We can make sure that your transition from regular care onto hospice care is as seamless as possible. You do have to ask questions up front. If we're having our sit-down meeting just to do a consultation, every question you think is going to matter or you might need the answer to at some point, ask it now. The hospice staff that is meeting with the family should have the answer, and if they don't, they should know where to find it. Those are my expectations.
Yeah. Well, you mentioned some patients will never be ready to pass.
Right.
How does that affect your process? How does that affect working with them and their families?
Well, the bottom line is respecting what the patient's wants and wishes are. If I'm the one out doing this consultation, I will sit right next to the patient, looking at them just like we are right now, and ask them why. What are your reservations? What are you worried about? What would you like to make sure is taken care of before you make this decision? Some patients will tell you a laundry list of things that they're worried about, that they want to make sure are taken care of. And if that's the case, then we just write the list down and we work our way down one at a time, and we slowly get all of those worries and wishes taken care of before we bring them onto service. So we will do some pre-service care to help them work through some of those problems. There are other patients that will just flat tell you, I am not ready to die. Those are the patients that typically are referred to us from a hospital. The family member is now the one making the decision because the patient is not able to. Hopefully, with good coordination, we're able to get them on service so that they don't have to pass away in the hospital. Sometimes we can't avoid it. So it's a very delicate balance, very delicate situation when you're managing somebody that's not prepared.
There's so much to keep track of, and it's an emotional time. So to be able to have a service that can provide all of that for you, and a team of experts, you guys and girls, you have been through this so many times. It's got to be peaceful for the family as well, to keep some of that static down, right?
Most definitely. It's a relief. Usually you'll see shoulders drop. You'll see a physical kind of manifestation of that relief, which is what we want. You know, we're not going to take everything away, all the feelings, all of the worries. We're not going to take all of them away in the beginning. Hopefully, though, through the course of care, by the time the patient passes away, we've addressed all of those worries that maybe the family members have left over, so that when the patient passes, it's a very peaceful, very calm, that's an ideal, anyway, situation.
And the best part of hospice, if we can get the patient onto hospice services sooner than later, then that gives the patient, the family, the team, the hospice team, more time to work with their needs and their wants and their expectations. So the whole hospice team can get together and work, to work through their fears and work through their needs to get them to a comfortable ending. And that's, the sooner that we can get them on, instead of waiting till the 11th hour, then that's a better outcome for everybody involved.
I want to ask about a few terms. What are advanced directives?
Advanced directives are very simply powers of attorney and do not resuscitate forms. So a power of attorney is a person that the patient elects to make a decision for them when they are not able. The most common one is a medical power of attorney. We see those most often. You'll have a financial power of attorney and a durable mental health care power of attorney that are a little less frequent. These documents are filled out by the patient with specific requests on them, like do and don'ts. Do not let them intubate me. Do not let them do any life-sustaining measures, things like that. They have a designee and then an alternate, typically. These people, the designee and the alternate, are going to be the people we will look to in healthcare for decision-making. The Do Not Resuscitate order is a pre-hospital or in-hospital form. It's the bright orange one page. You can get it at your doctor's office if you wish to not have any life-sustaining measures done. To clarify, Do Not Resuscitate means to not initiate CPR or any of the chest compressions, life extending when you stop breathing on your own. It does not mean do not treat. So there's an important distinction in that form. You want to not be resuscitated should something take its natural course, which is not the same as no treatment.
When we talk about final arrangements, how about that term? What are final arrangements?
Final arrangements are your final resting place. That can look very different. We've had some neat final arrangements. You can go with the Neptune Society down to a coral reef and become a part of a biological reef system for the fish and native creatures. I don't go into the deep water at all. It's not my thing. But you can be a part of a natural reef. You can be a tree if you want. They're called eternitrees. You can be interred in a cemetery. You can be buried. That's a final arrangement. So it's literally your final destination. Where do you want to be? What does that look like? Do you want to stay with family? Do you want to be cremated? Do you want to be a firework? Do you want to be in jewelry that somebody can wear maybe as a necklace or a ring? Do you want to be blown into glass and be a sun catcher? There's so many different things that you can do, but a final arrangement is letting your family know, letting the hospice care providers know what your intentions are for the end of your life. You can pre-plan for those. You can go to any funeral home locally or as far away as you can find one and make your arrangements. These arrangements can be prepaid plans. They can be paid in full ahead plans. You can make your final arrangements at the death call when we're there taking care of your loved one that's passed away. We prefer not. We like to have these things set up as far ahead as we can, at least in the course of the hospice care, so we can help smooth out that process. We want to make sure that you call us when you feel or think your loved one has passed away, and then you have to do nothing else. You're just present. We come, it doesn't matter what time of the day or day of the week, and we should already have all of this information. We make all of the phone calls. We do everything. So you have to do nothing as the loved ones and family members. So final arrangements are things that we talk about at the admission to hospice.
Here in the tri-state area and in the region, there are lots of organizations that provide hospice services. What makes KRMC Hospice special?
Well, we are the only nonprofit in Mojave County with a hospice house. We are also a 5-star Medicare certified program. We have been working on that for, I think since...
Well, a couple years now.
Has it been?
5-star, just the star rating came out in hospice a couple years ago. So it's a new rating.
What does it mean? Can you give some details on what it means, how it works?
Say when people are researching, you can go to a website called Care Compare, which is a Medicare website, and you can pick not only hospices, but home health and hospitals, things like that Medicare recognizes through these programs. And so your star rating is what's going to generally give you an idea of how good this hospice program is, right? So it's 1 to 5 stars. And so we hit our 5-star rating. So we're very proud of that. That's a huge piece. And we're the only hospice with a 5-star rating in our area. So yeah, not Mojave County. There's one other, but in our local area of Kingman, we are the only 5-star hospice.
Yeah. All of the feedback that we get from our surveys, from our families when we've taken care of someone, we take all of that information back and we fix problems in real time. So these surveys are 2 to 3 months behind the passing of a patient. But as soon as we get that information back that there is room for us to improve, that's exactly what we do. I don't let any grass grow under my feet when I get that information. I'm immediately trying to dig down and figure out where we went wrong, what happened. I will audit charts. I'll do whatever I need to do to figure out what the problem is so that it can be effectively handled. And what I mean by that is usually education-based. People don't get in trouble. But it gives me an opportunity to correct a thought process, correct clinical process, something, which is what leads to the next patient's family not having to go through that. And that's what my goal is, always to hear our patients, hear our families, correct problems. I like to do it in real time if at all possible, and make sure that if something did negatively affect a family, it doesn't happen again.
How many employees does KRMC Hospice have?
Between the hospice house and our outpatient hospice program, we have about 30 employees.
That covers a whole range of different positions. Can we talk about some of those?
Absolutely. So we have a patient-centered care program, meaning that we have a variety of different disciplines that will come out to help provide care to our patients and their families. We in hospice are not ever just taking care of the patient. There's always somebody, a friend, a family member, a distant relative, a neighbor. There's always somebody that's involved in this care. So it takes a village to be able to provide the care that these patients need. Of course, we have clinical staff. We have nurses and nursing assistants. We have mostly RNs. We have 1 LPN, and all of our nursing assistants are licensed. We have a small administration. We're not top-heavy when it comes to administration. Candy and I are pretty much it, which is good because you want the bulk of your workforce to be supported and not bogged down with nonsense. I shoulder all the nonsense.
Yeah, I was going to say always looking over their shoulders and
Yeah.
wait. Yeah, right.
Yeah, no. And anybody that works with me knows that you're never going to be in trouble. Yeah. You have to do something pretty egregious to be in trouble. Mm-hmm. We also have chaplains and social workers as part of our support team. The chaplain and our social workers help with all sorts of different issues that we might have in the home. We have different levels of coping. We might have a pre-bereavement circumstance in the home. We just might have high needs, meaning that the patient's needs are beyond clinical. I think you could call it an existential crisis. We have sometimes that we have to field,
Sure,
and
yeah.
a chaplain is actually a pretty good person for that.
Yeah.
But also, people have to know where they're going in a not a literal sense. There has to be some faith, and that's why we keep the variety of people that we do. We have something for everybody. We have a bereavement counselor as well. We provide support groups for our bereaved and pre-bereaved. Some of them are going to be large groups. Some of them are going to be smaller. We have a couple that are structured. So there's a theme and structured conversation to make sure that everybody gets what they need out of that group. We also have one-on-one bereavement support for the family members and loved ones that need that and or are uncomfortable in a group. And then we also have our volunteers. So our volunteers are present for the daily functions of the Joan and Diana Hospice House, but they also go and do one-on-one visiting, companionship, and care with our patients. You'll find a volunteer sitting with a patient for an hour or two for the caregiver to go run an errand or maybe a doctor's appointment for themselves, go to the gym, self-care. And our volunteer will sit with that patient and maybe play cards, read a book, do life review with them, visit, so they're not by themselves. And then we have our medical director. We have a nurse practitioner that works with us. So we have a robust team of people to provide care. There's very, very few times I can even think of that we didn't have the right person for a situation.
If you're just joining us, this is Focus on Your Health. I'm TG LaFredo, and this week we're focusing on KRMC Hospice. You're hearing from Susan Shaver. She's the clinical manager of hospice and the Joan and Diana Hospice Home. And you're hearing from Candy Huerta. She is the director of home health and KRMC Hospice. So many aspects, so many branches of medicine. The purpose is to prolong life and think about quality of life and squeeze every last drop out of that lemon. And we know that hospice is different. Can you talk a little bit about the philosophy of hospice?
So in a nutshell, the hospice philosophy is quality over quantity. Your disease process has reached a point where there are days no longer guaranteed. So now what are we going to do? The doctor just told you 6 months or less. That's the phrase that is the go-to for every physician. 6 months or less, 6 months or less. That can really destroy somebody's mindset if somebody that you trust tells you you have 6 months or less. We have to go in and have a conversation with these patients after they've heard those devastating words. So my go-to, because the hospice philosophy, if you read it, is about 3 paragraphs. I don't have them memorized. What I do have memorized is this. The doctor just told you that your life expectation is limited, meaning that you are not guaranteed too many days anymore. So what are we going to do about that? We're going to focus on the quality of the days that you have left. We're going to stop counting. When we stop counting days and start focusing on experiences, it makes things better. It may not sound like a great thing. It may not feel like a great thing initially because that's hard. I can't imagine what that would feel like. I'm not ready for it. I understand death and dying, but I'm definitely not ready for it. So that's what I tell my families is we need to start focusing on you having good days, the best days that we can manage, and stop focusing on how many you might have left. Our philosophy is just that. We want to surround you with love and support. We want to encourage exploration of things that maybe you've never done before. We want to support you in a trip, for a week, for a month, for a weekend. We want to support you with that. We want to assist with getting in touch with family members. We want to think outside the box. We want to set goals for these patients and their families that are complex, because that's what the patient feels like they need, or simple, like I want to have coffee on the back patio one more time. No problem. I can figure out all the logistics around getting you on that patio. It would be my honor to help you meet that goal. So the philosophy is different. We don't any longer focus on, did you take your medicine? Have you made this doctor's appointment? Did you weigh yourself today? Are you doing, the barrage of questions that comes along with what are you doing? How are you doing it? Are you doing it the way it's prescribed? There are disease processes that exist outside of cancer that have a time frame attached to them from the moment you're diagnosed. Congestive heart failure, COPD, renal failure, liver failure. They are not healable conditions, they're treatable conditions. So at some point, unless something comes up that's more serious than your congestive heart failure, for example, that's what's going to lead you to the end of your life. Eventually, the functionality of your heart is going to diminish. The complications from having a heart that can't pump effectively is going to cause lots of discomfort. That's when you want to elect hospice. Stop chasing these doctors around. Stop being so overwhelmingly dedicated to medications and scales and boundaries. Mm-hmm. So for hospice, we want to help you kind of blow out some of those boundaries that you've had with your chronic disease and do our very best to give you better days.
Let's talk about the different types of care that KRMC Hospice provides.
Okay. So a routine home care is what Medicare's standard expectation is. Their expectation is that we will take care of you in your home, wherever your home is. It can be a private residence, it can be an apartment, it can be a motel room, it can be your van. It doesn't have to be any place structured and formal. It just has to be safe, and it has to be your space. So that's what Medicare expects from us. They want us to bring medical equipment to you. They want us to bring medications to you. They want us to bring all of our services to you. So nurses, nursing assistants, social workers, chaplain, bereavement, volunteers. Our program comes to you. We don't provide 24/7 care in the home, wherever your home is, so we aren't going to be a replacement for a caregiver. We are a supplemental program in your home, and that's hospice across the board. It's a supplemental program. If you have high needs, let's just say we have a disease process that is really high need, the caregiver is exhausted. Alzheimer's disease, for example, is very exhausting to the caregivers. Sleep patterns are disrupted. We have pacing sometimes. We have people that are requiring every single meal be prepared. The caregivers in those homes get worn out really fast. So our hospice house is where we can take the patient to give the caregiver their break. Medicare allows that we give the caregivers a break for 5 full days, about every 6 to 8 weeks. If we have something that is unique going on in the home, we can do respite a little bit more often, about once a month if we need to, but typically it's about 6 to 8 weeks. General inpatient care is the most acute level of care that we have, highest level of care we can provide. That's for patients that have symptoms that are out of control. We've tried everything that we can do in the home to manage their symptom, get it maybe down to a manageable space, but we just can't, despite everything that we do. So we bring them to the hospice house, and this is what prevents rehospitalizations. We don't want our patients going back to the emergency room or being admitted to the hospital. I mean, let's be honest, that's not really a place to heal.
Yeah, and they don't want to go there.
Right. Typically, they don't want to go there. So we bring them to the hospice house. We give IV medications. We give them almost one-on-one care. We actively manage those symptoms and get them under control as soon as possible. That's also Medicare's expectation. We will not dilly-dally with somebody like this. When we bring them in under general inpatient care, we need to get work done around the clock to get these symptoms managed and then get them back to their home.
KRMC Hospice provides a wide range of services. I know you have a bunch of staff, but are you able to accommodate all the different inquiries and people who come your way?
Yes, we can. We get referrals from the hospital, from doctors' offices, from individuals in the community. We get referrals from hospitals outside of our area, so Las Vegas or Phoenix, for example. When we receive these referrals, we prioritize them. So if you're currently in the hospital, you're going to be bumped to the top of the list. Our goal is to get you out of there. Again, that's not a place most people want to be any longer than they have to. And then from there, we call every single person that makes an inquiry that we get a referral for. We call them and ask them what their timeline is. Are you wanting to have somebody come over immediately? Are you going to have family come from out of town? You want to wait until they get here for us to have the conversation. So we can then prioritize and we schedule the consultations and admissions accordingly.
Do those referrals have to come from a medical professional? That is, if I have a friend or family member who is critically ill, can I, as a non-medical person, just call and make a referral?
Yes, you can.
And does that affect insurance and those sorts of issues?
We have a
Not at
team
all.
that will look into the insurance and let them know what their hospice benefit is and if they have that benefit. So
If we have insurance issues, what we've done in the past is we've done an education visit. So we'll come out to the home and we'll do an education on what hospice is. And if they ultimately have an insurance issue, we work that out internally if we can. Or we will find another hospice service provider that accepts that insurance and hand over the referral. The goal at the end of the day is to get the patient the services that they need wherever that is, even if it's not with KRMC. I, of course, selfishly want them all because I have a great team and I know I'm going to provide the best care, but that sometimes is not a reality.
Yeah.
Insurances are
Yeah.
insurances.
Yeah, we know.
Yeah.
It's a favorite punching bag on this radio program.
I can imagine.
We haven't gotten any hate mail yet, so I think it's,
yeah, because they know the reality.
you know.
Yeah.
If we have, let's say, a family member who has a disease that will, in the end, lead to that family member's death, at what point do I know that it's time to introduce hospice into the conversation?
So the standard answer is when they are done seeking treatment options. If you have somebody, now, I guess I'll add in here real quick. Medicare has definitions for every disease process: pulmonary disease, which is lung disease, heart disease, liver disease, all that. So Medicare has this defined for all of us already. But there's a little caveat with that. So if you have a little bit of heart disease, you're going to have a little bit of kidney disease because they're buddies. They like to do things together, the heart and the kidneys. Or you have kidney disease with a little bit of liver disease. You would still qualify for hospice services because of the complexity of that combination. They work against each other ultimately. So when we're putting somebody on service and you have questions about what would qualify, we have guidelines that we use during those conversations to just ask some questions. Sometimes you just know. I don't know how else to put that, but sometimes we go out to a patient's home because a family member called and they said, my grandma hasn't eaten anything for a week and she's noticeably lost weight. I'm not sure what to do. Can somebody come? She's refusing to go to the hospital. No problem. We totally can, and we do. Sometimes we have to get our medical director in the car and take him out there with us, and he will be the one ultimately that decides in that case, yes or no, we're bringing this person onto service. Some of our patients won't have a formal diagnosis of anything at all.
Right.
Sometimes they're just 99 years old.
Yeah.
And their body is moving through the natural aging process, which does also lead to death. So we have guidelines, we have structured literature from Medicare that tells us where to start. The nurses then know what to assess for when they're doing this, and then they call our medical director with their assessment. And if need be, like I said, we'll take our medical director to the patient and get them prepared for service that way.
We've talked about the many branches of KRMC Hospice, and certainly not everyone who enters KRMC Hospice will spend time at the Joan and Diana Hospice Home. However, the hospice home is a special place. Can we talk about that a little bit?
Yes, we can. It is a very special place. When I first moved to Kingman and interviewed to work for KRMC Hospice, they asked to meet there for the interview, and I expected something more like a nursing home. And when I walked through those doors, I was shocked. And I think everybody saw it, because you walk in this building and you have a giant fireplace with big overstuffed leather couches and chairs. You have the smells of a home and not a nursing home or hospital type facility. So that kind of immediately took me off guard. I expected it to be a nursing home, frankly. When I completed the interview, I asked to take a tour to go see the patient rooms and figure out maybe if they just spray cookie smell in the main lobby type of thing. And no, the patient rooms, so we have 12 patient rooms total. All of them are private. All of them have their own private bathroom. They all meet the specifications of the state of Arizona, which has a very specific definition of what each room needs to look like, down to the square footage, a window. I mean, they're very, very specific. So all of these rooms meet that expectation plus. You have 2 hallways of 6 rooms with a central nursing station. You have reflection rooms and family rooms. So if you need a minute in a space that's nice and quiet and private, we have those rooms available. The family room has games and a TV and things for the younger folks to do. We have a kitchen, a satellite kitchen that's in the hospice house, so that we can prepare cookies and meals, anything that the patients want, we can prepare it in there. We have a private dining area and a more public dining area. So if you wanted to come and have a meal, we can wheel or escort the patient into the private dining area. You guys can sit and have breakfast, lunch, or dinner together as a family without being interrupted. And we also have a giant back patio, backyard that's walled in. It's got walking trails, sitting areas. You can see wildlife. The bunnies and stuff make their way in and out of there. We have a butterfly garden, a couple of different areas. We have patients, families come and purchase a butterfly that can be inscribed with the patient's name, a statement in remembrance of. They can put anything they want on there. And then we call them when the butterfly comes back in, and they can either put it in the butterfly garden so that they have a space that they can always come back and visit, or they're welcome to take it home with them if they want. Oftentimes they choose to leave it in the butterfly garden because they want to come and talk to their loved one. They use that as a space to come and visit. It gives them a tangible space or representation of their loved one. Yeah. So it's a beautiful building. It looks like a big ranch-style home. It doesn't look like, you drive right past it, I think, if you weren't paying attention.
Yeah, agreed. It's a lovely space. Well, Susan, in the moment that we have left, I want to talk about a program that you're involved with. I know that we've chatted about it in the past, but the program's called We Honor Veterans. Can you talk a little bit about it?
Yes, we do participate with the Veterans Administration in a program that we use to honor veterans that are on hospice service. So we have quarterly meetings with the VA, because they have requirements for this program that we have to meet. Reporting requirements, they want to know how many veterans that we're servicing. They want to know details. So we participate. We do everything that they ask because it really is an honor. Not too many hospices participate in this program. What we do when we have a veteran on service is we typically ask them what branch of the military they were in and if they were service related. So were they World War II? Were they Korea, Vietnam? I think we're moving into Desert Storm veterans now. So we ask them just a couple of brief questions. Some of them want to share everything. Some of them want to share very little. So we take that information, we report it back to the VA. We put a framed certificate with the patient's name on it, the branch of the military that they were in, with a pin for a thank you. So, and we personally deliver that back to the veteran. I have always been raised to shake the hand of a veteran and thank them for their service, so it really is an honor. And then on the backside of the care that we provide when the veteran has passed away, we tell the funeral home that we have a veteran that they'll be picking up so that they bring a flag and they drape a flag over the patient when they're taking them into their care, which is the biggest, most important thing for me, is that these veterans, as well as all of our patients, receive the dignity and respect that they deserve all the way through.
You've been hearing from Susan Shaver. She's an RN and the clinical manager of KRMC Hospice and the Joan and Diana Hospice Home. And from Candy Huerta, she's an RN and the director of Home Health and KRMC Hospice. Both nurses to the core and two of the nicest people you'll ever meet. Ladies, thank you so much for your time today.
Thank you for having us.
Welcome.
It's our pleasure.
And that is the program. Let's focus on your health. For more information on KRMC Hospice, you can call 928-692-4680. That's 692-4680. I'm TG LaFredo. Thank you for listening. Stay healthy, and we'll catch you next time.